everyone. My name is Christiane Roumie, and I am a professor of medicine at Vanderbilt and the Tennessee Valley Nashville VA healthcare system. Today we are talking about a large, real-world target trial emulation study looking at diabetes medications and kidney outcomes in veterans, many of whom are older. This population of older adults is not always well represented in clinical trials.
I am Emulation Hung, and I am a professor of medicine and nephrology at Vanderbilt University and the Tennessee Valley Nashville VA healthcare system. This study is interesting because we use a trial emulation approach instead of conducting a clinical trial, which can be costly and take a long time. The trial emulation is a quasi-experimental research design that uses observational data to emulate a randomized trial structure. We follow veterans who started one of the three medications, GLP1RAs, SGLT2 inhibitors, or DPP4 inhibitors.
Exactly. We followed each group until a composite kidney outcome, including a 50% drop in kidney function, progression to kidney failure, or death. We censored people who discontinued their medication or left the health system. We were especially interested in the a priori subgroups of patients who were older age.
After balancing the groups with propensity score weighing, they ended up with more than 130,000 treatment episodes, or about 40,000 in each medication group. Median age was 69 years, the average eGFR was 75, and the veterans had diabetes for about 10 and a half years. Most of the patients in each group had mild frailty, so this is very much a real-world aging population with diabetes.
And the results were pretty striking. Event rates were lowest for SGLT2 inhibitors, followed by the GLP1RAs. The DPP4 inhibitors had the highest event rates. At 5 years, the proportion of composite outcomes was 4% versus 3% versus 5% for GLP1RA, SGLT2, and DPP4. So the absolute risk reduction for CKD and death at 5 years was 1% for GLP1RA, which is a number needed to treat of 91. For SGLT2 inhibitors, the 2% reduction is a number needed to treat of 50.
That's right. And when they looked at kidney-specific events alone, the pattern held. SGLT2 inhibitors again showed the strongest protective association, but GLP1RA were also kidney protective, and results were linked with substantially fewer kidney events. The hazard ratio was 0.79 for GLP1RAs and 0.48 for SGLT2 inhibitors. That's a meaningful reduction.
What we found was especially important. These benefits were consistent among subgroups, whether veterans were older, had different levels of kidney function, or had varying degrees of proteinuria or frailty. It really reinforces the value of these newer drug classes for primary prevention, especially in older adults who are at higher risk for kidney decline.
Bottom line is that in this large veteran cohort, GLP1RAs and SGLT2 inhibitors were associated with better kidney outcomes and lower mortality compared with DPP4 inhibitors.
These findings are consistent with the results of clinical trials of SGLT2 inhibitors and GLP1RAs on kidney outcomes, and adds to the growing evidence that these medications can protect long-term kidney health in older patients who were underrepresented in clinical trials. Thank you.
This podcast is copyrighted by the American Society of Nephrology. All rights reserved. All content in this podcast is for informational purposes only and is not intended to be medical advice. This podcast should not be used in a medical emergency or for the diagnosis or treatment of any medical condition. Please consult your doctor or other qualified healthcare professional if you have any questions about any medical condition or before taking any drug, changing your diet, or commencing or discontinuing any course of treatment. Thank you for listening to this podcast from the American Society of Nephrology.